topic of discussion is rheumatic heart disease or rheumatic fever. Okay, rheumatic heart disease and rheumatic fever are very important for theory purpose. In last few years, rheumatic heart disease, it came as short note, the cardiac manifestations or the extracardiac manifestation as short note. But you need to know all the manifestation, whether it is cardiac or extracardiac, neurological, subcutaneous and musculoskeletal manifestation of rheumatic fever. And coming from the etiology, rheumatic fever is caused by the Group A Streptococcus, very good, GAS, Group A Streptococcus or Streptococcus that is more prone to injure the throat in children or early adults in the countries or in the locations that is affected by poverty, that is affected by overcrowding and low or poor socio-economic status. So the sore throat that is caused by the Group A beta hemolytic group Streptococcus, these are designed to affect the other systems of our body like central nervous system, musculoskeletal system and cardiac system after initial sore throat sequel. 15 to 20 days or 1 month to 6 weeks, the rheumatic fever sequel will come. So it pains the throat, but it leaks the heart. Okay, so the sequel of rheumatic fever is more dangerous whenever the initial treatment or initial insult has been inadequately treated. Okay, then the carditis or the neurological manifestation will prevail. So today our topic of discussion is rheumatic heart disease, and objectives of today's class: define rheumatic fever and rheumatic heart disease, describe the etiology, risk factor, clinical manifestation, diagnostic criteria, management to some extent, the pathophysiology and symptoms in rheumatic heart disease, explain the management, describe the management and describe about the preventing method. But first, rheumatic heart disease is most common acquired heart disease in children, especially in developing countries. So whenever there is lack of money, lack of quality of life or lack of ample of space or lack of treatment, then rheumatic fever will leave the dreadful sequences. And rheumatic heart disease is a chronic heart condition caused by rheumatic fever that can be prevented and controlled. So what is rheumatic fever? A sore throat that can lead to a broken heart. So broken heart may be some other causes, but rheumatic fever heart disease is caused by the beta hemolytic streptococcus. Immunologically mediated inflammatory disorder. Okay, Group A streptococcal pharyngeal infection. The initial insult is Group A streptococcal pharyngeal infection. It is a multi-system disease affecting the connective tissue, particularly of heart, joints, brain, cutaneous and subcutaneous tissue. Rheumatic fever is not a communicable disease but result from a communicable disease. So the streptococcal pharyngitis, the initial most insult of the pharynx due to the beta hemolytic streptococcus organism that is communicable, that can spread from droplet infection in close proximity in overcrowded population. But the rheumatic heart disease, that is not communicable. So as the initial insult or initial disease sequence is communicable, so it can be prevented in primordial level of prevention. Next. So rheumatic fever, next is sequel is rheumatic heart disease. Epidemiological point of view, this cannot be separated because of molecular mimicry of antigen structure between the group A beta hemolytic streptococcus and that of the connective tissue of our heart, brain, subcutaneous tissue and muscles and bone. The clinical course of rheumatic fever involves a childhood infection with complication in adulthood. So a patient can develop rheumatic heart disease, the symptoms like chest pain, breathlessness, palpitation resulting from a valvular defect in his or her adult life. But the initial infection, the first attack of or the first exposure with that antigen occurs in early childhood. So there may be a long latent period or long window period before the cardiac manifestations appear. So epidemiology, common cause of heart disease in 5 to 30 age group throughout the world accounts for 12 to 65% hospital admission related to cardiovascular disease in developing country. So again, I am telling that this is a disease of underdeveloped and developing country because of the lack of resources, lack of space, lack of treatment and lack of sanity and hygiene. It is prevalent in range of 5 to 7 per thousand in 5 to 15 age group. 1 million cases of rheumatic heart disease, and rheumatic heart disease constitute of 20 to 30%, that is substantial amount of hospital admissions due to cardiovascular disease. And the streptococcal infections common in children living in underprivileged condition, I told you earlier, and rheumatic fever accounts for 1 to 3% of the cases. So all the streptococcal pharyngeal infection don't go up to the rheumatic heart disease phase if treated adequately, if treated judiciously. So risk factor is overcrowding, underprivileged, close proximity, lack of food, poverty, lack of quality, physical quality of life. So age is risk factor, it is children, because children, they don't separate themselves from playing. If one children is affected, he or she might not be that much of aware that he or she won't go to playground or won't go to play other children of his age group until and unless he or she has been warned by his parents. Okay. Next, familial predisposition, overcrowding, poverty, poor hygiene and lack of access to medical care. So it is evident that rheumatic fever and rheumatic heart disease starting from the streptococcal pharyngeal infection is a disease of the poor and lower socioeconomic status generally. Everyday oral activities, any infection or other medical condition that involves the maneuver within the intraoral cavity or like gum, like tooth. So any medical or surgical, minor surgical procedure that involves the oral cavity or the dentier or the tonsils or the facial pillar, they may be a cause of incorporating the bacteria into bloodstream from the mouth to bloodstream. Okay. Weakened immune system, certain dental procedure and infection or other medical condition. So it may be come from your clinic. If the clinic or the medical professional is not quite trained and not quite aware. So Streptococcus pyogenes, also known as Group A Streptococcus, is the causative agent in Group A streptococcal infection streptococcal pharyngitis, acute rheumatic fever, scarlet fever, acute glomerulonephritis. So the disease like PSGN is also caused by the group A Streptococcus. So pharyngeal infection is very important to treat in children because inadequacy of treatment may affect the children's quality of life in later adulthood. Okay, this is clear? Next, so pathophysiology, starting from the sore throat, starting from the infection of the throat, then immune response, formation of antibody, lymph node, B lymphocyte, and this anti-streptococcal antibody, they find the antigenic similarity of streptococcal antigen with that of the connective tissues of heart and other muscles of our body. So the vegetations, myocardial astroph body, fibrinous pericarditis, all are causes of antigenic response to a molecular level similarity between these two structures because of the sharing of common and amino acid sequences. Okay, the streptococcal antigen, the amino acid sequence is somehow similar than the connective tissue protein of our body. So body produces antibodies against streptococcus. These antibodies cross-react with human tissues because of the antigenic similarity. This is called molecular mimicry. Because of the amino acid sequence is similarity between group A Streptococcus and human tissue. So this is a immunologically mediated inflammation and damage to human tissue which have antigenic similarity with streptococcal components like heart, joint, brain, connective tissues. Okay. So the antibody produced by the body own immune system. If the body own immune system produce antibody, then which type of immunity is called? Cell mediated immunity or humoral immunity? Mostly humoral immunity. B cell, plasma cell, circulating antibodies, all are humoral immunity. Right? Next, so clinical feature, sore throat, exudative patch in tongue, in tonsils. 10 to 14 days later, much longer gap for the chorea, because much longer gap for the central nervous system manifestation to come. And the affected area mostly joints, heart, skin and nervous system. Nervous system manifestation is latest to appear. Earliest to appear is the joints. Okay. So streptococcal sore throat, tender lymph node of the cervical region, group level 1 to level 6, strawberry tongue due to congestion, excoriated nares. This is very important. Crusted lesion in infants, because this crusted lesion from the nares is the main source of communicability between an affected person to a non-affected or naive person. Tonsillar exudates in older children, abdominal pain, and this is more common in winter and rainy season. But which is the gold standard of diagnosis to determine the etiology? That is positive throat culture to isolate the organism. So streptococcal sore throat with fever, recurrence of fever with manifestation of acute rheumatic fever and shortness of breath due to air entry obstruction. আসছে আস্তে আস্তে ওখান থেকে করা যাবে তো তুই কর এটাকে বারবার বাড়ির রিমোটের মতো থাপড় দিতে হচ্ছে হ্যাঁ যখন ও তুই ওখান থেকে করছিস আচ্ছা ঠিক আছে সো ফিচার্স ফলোইং আপার ওয়ে ইনফেকশন উইথ গ্রুপ A streptococcal silent period is 2 to 6 weeks Sudden onset of fever, pallor, malaise and fatigue. Commonly Group A streptococcal infection is subclinical. Such cases confirmed using streptococcal antibody testing like anti-streptolysin O, anti-DNase B. These are the antibodies. These are produced against streptococcal antigen. This can be found to document the presence of streptococcal pathogens organism. Next, so there is no definitive test to diagnose a rheumatic fever. So there are variety of clinical signs and symptoms and variety of the organs that are involved by the rheumatic fever. So in the year of 1944, Dr. T. Duquette Jones, he developed a criteria, a bunch of criterias. Few are he named as major, few he named as minor, few named as essential. Those criteria, by combining one major criteria or two minor criteria, one minor criteria and two essential criteria, by combining this kind of criteria, we have to confirm the rheumatic fever and then treat the patient accordingly. So that was the Jones criteria in the year of 1944. But after advent of investigation, after advent of newly synthesized antibody panel, now the diagnostic criteria is based on the modified Jones criteria. Okay, so it is a very favorite questions for the examiners to set it up on the theory papers. What is modified Jones criteria? So modified Jones criteria is not a single criteria. It is a spectrum of criteria involving multiple organs, system specific signs and symptoms. Okay, am I clear? So the modified Jones criteria starts with major criteria, joint, that is joint of our body, musculoskeletal system. So it is important, whichever is written in red, that is migratory polyarthritis. This is the term. This is the term to be used to describe the musculoskeletal or joint affection of rheumatic fever. That is migratory polyarthritis. What is the meaning of migratory polyarthritis? Because the affection migrates from one large joint to another, leaving the previously affected joint as it was before. Okay, mostly the large joints are affected, like knee, like elbow. Okay, so usually more than 5 joints affected and mainly large joint: knee, ankle, wrist, elbow, shoulders. Redness, warmth, swelling, pain, movement limitation. These are the clinical features. Quick to appear, last for 3 to 7 days, subside and then reappear in other joint that was previously normal. And the joint that is being affected, that will be normal after 5 to 7 days. So the affection is migrating from joints to joints. The polyarthritis is responded well with salicylate and NSAIDs, commoner in older patients, small joints and cervical spine, less commonly involved. Okay, so the modified Jones criteria, the first criteria involves the very favorite thing, joint. Next criteria is carditis. Next is carditis. What type of carditis? Rheumatic fever? Pancarditis. All the layers of heart are involved. Namely, the endocardium, the inflammation is called endocarditis. Myocardium, the involvement is called myocarditis. And the pericardium, the outermost layer of the heart, is involved and it is called pericarditis. So, endocardium, myocardium and pericardium, all the 3 layers of the heart are affected. So it is called as pancarditis. Pan means global. So pancarditis. So for the pericarditis, we will get patient pericardial rub, ST changes, friction rub, endocarditis, valvular changes, pansystolic murmur of mitral regurgitation, with or without aortic regurgitation. Other signs are cardiac enlargement, soft S1, S3 gallop, that is heart failure sign, congestive cardiac failure. So these are the symptoms and signs that we elicit in patients of cardiac involvement of rheumatic fever. Carditis is the only manifestation of rheumatic fever that leaves a sequel and permanent damage to the organ. So among all the criteria, among all other systems, as I told you earlier, this is a multi-system involvement disease. Only the heart that imparts a lifelong, permanent, irreversible damage or changes after rheumatic fever. So first criteria was joint, major criteria. First major criteria was joint. Second major criteria is carditis. Which type of carditis? Pancarditis. Which type of arthritis? Migratory polyarthritis. Okay. These 2 to 3 phrases are very important to know the concept and to let the examiner know that you know the thing. Migratory polyarthritis, pancarditis. So these are the terms. Next, nodules. Which type of nodule? Subcutaneous nodule. Subcutaneous nodule tends to appear mostly on extensor surface. Okay, the dorsum, olecranon process, the shin bone. So this is a late manifestation, 3 to 20%, 6 weeks after onset of rheumatic fever. Non-tender, subcutaneous nodule on bony prominences. So this is non-tender. Migratory polyarthritis was tender swollen thing, but subcutaneous nodule is non-tender. So painless, increase and appearance of nodules. Small, painless, mobile, hard lumps beneath the skin. Most common along extensor surface of joint, knees, elbows and wrist. Also on bony prominences, tendon, dorsi of the feet, occiput or the cervical spine. Pinhead to almond size. I will show the pictures later slides. Okay. So pinhead to almond size, small painless nodule, mostly prevalent on the extensor surface. Okay. So number 3 criteria is over. Next. So these are the nodules. These are the nodules. বাড়ির বৃদ্ধদের অনেক সময় দেখতে পারবি যারা ঠাকুমা দিদা এদের সাথে বাস করিস বা ঠাকুমারও মা যাদের বাড়িতে আছে, ঠিক আছে, আগেকার দিনে অত অ্যান্টিবায়োটিক পেনিসিলিন এত ছিল না, পাওয়া যেত না বেশি, আর যেগুলো পাওয়া যেত সেগুলো এফিকেসি নয়, তো অনেক সময় সাবকিউটেনিয়াস নোডুলস আমরা দেখতে পারি। সো দিস আর ডরসাম অফ হ্যান্ড, নি, olecranon fossa. Just look at the picture. All painless, small, pinhead to almond size, subcutaneous, non-tender nodule are appear mostly on the extensor surface. Okay. Next, the last major criteria is erythema marginatum. So erythema marginatum. Erythema means the redness, plaque, macular plaque, and marginatum. So early manifestation less than 3%, mostly late manifestation. Erythematous, serpentinous, non-pruritic macular lesion with pale center. That is the skin lesion is red. Serpentinous মানে সাপের মতো, ওর যে edge have wavy like snake. Non-pruritic, so no itching complained by the patient. Macular lesion with pale center. That is, the center is void, center is pale. Pink macules, clear centrally, serpentinous spreading, has slightly elevated red margins. More on trunk and limbs, almost never on face. So this is very much important differentiating point between erythema marginatum and that are rash from SLE. SLE rash, butterfly shaped rash, appears to cheeks, around the nose, okay, sparing the nasal bridge. So this erythema marginatum, the skin manifestation of the rheumatic fever that almost never on face, so worsen with application of heat and often associated with chronic carditis. So this is the last major criteria, erythema marginatum. যে ছবিটা দেখাই ওদের দেখ. So according to the description, maculopapular rash with wavy margin, pale center, center is white, pale center, okay, non-pruritic, slightly elevated. এই ছবিটা অ্যান্টিসিপেট করতে পারবি স্লাইটলি এলিভেটেড কিনা। এরকম আমরা আর কিসে দেখি এরকম র্যাশ? টিনিয়াতে দেখি, তাই তো, যেটাকে আমরা দাঁত বলি, টিভিতে অ্যাড দেখায় বিটেক্স এর। তাহলে কিন্তু সেটার সাথে কি পার্থক্য হলো? ওটা ইচিং হয়, এটা নন প্রুরাইটিক, ঠিক আছে। সো দিস ইজ সার্পেঞ্জিনিয়াস স্প্রেড, পেল সেন্টার, নন প্রুরাইটিক, ওকে, মোস্টলি অন ট্রাঙ্ক and limbs but almost never on face. Acha, another major criteria I missed, that is Sydenham's Chorea. So that was five major criteria: joints, carditis, erythema marginatum, subcutaneous nodules, and last Sydenham Chorea. So what is the Chorea? Chorea means repetitive jerky movements of hand or extremity, semi-purposeful jerky movements, deranged speech, muscular incoordination, and facial grimacing. So all the muscles that have connection with the brain or the neuromuscular junction, those are affected and exacerbated by stress and disappears with sleep, more common in female. So semi-purposeful jerky movement, late manifestation of this central nervous system manifestation, and clinical maneuvers to elicit chorea demonstrate milk-made grips and handwriting examination, self-limiting, or in the advanced case the treatment is with haloperidol. So what is milk-made grip? Milk-made grip, বাড়িতে তো এখন আর গরু থাকে না, তো আমরা মিল্ক-মেড যারা হচ্ছে গোয়ালা যাদেরকে বলতো, those person have a grip of alternate compression and decompression, okay. So this is the milk-made grip that will be demonstrated by the patient of neurological involvement by rheumatic heart disease, okay. And handwriting examination, semi-purposeful jerky movement, and the patient will have troubled handwriting, okay. So hopefully the major criteria are over. So to recapitulate the major criteria, one is migratory polyarthritis involving joint, next is pancreatitis, subcutaneous nodules, very good, next erythema marginatum, and the last is Sydenham Chorea or Chorea, okay. And the minor criteria are fever, Arthralgia, then epistaxis, abdominal pain, okay, bleeding. So high grade fever lasts for about 12 weeks, tend to recur, and associated with weakness, malaise, weight loss, and anorexia. Arthralgia, pain in one or more joints without the presence of arthritis. Epistaxis, abdominal pain, these are the minor criteria, okay. So coming to the essential criteria, so lab diagnosis. So high ESR, erythrocyte sedimentation rate, is a indicator of chronic infection. So rheumatic heart disease is a chronic infection. So ESR or erythrocyte sedimentation rate will be remarkably high. তুই ওটা কি পড়ছিস? বইয়ে কি লেখা আছে? শুনছিস? তোকে বলছি, বইয়ে কি বই পড়ছিস? প্যাথোলজি? আচ্ছা ঠিক আছে, ওটা কি বই, কি নাম ওই বইয়ের, কোন অথরের? ম্যারো। ম্যারো নোট ওগুলো বিপদ করবে ভবিষ্যতে, এখন না। ম্যারো পরে, আগে কনসেপ্ট বানিয়ে তারপরে নোট পড়বি, ঠিক আছে। হাই এসআর, অ্যানিমিয়া এন্ড লিউকোসাইটোসিস, অ্যানিমিয়া অফ ক্রনিক ডিজিজ, নর্মোসাইটিক, নর্মোক্রোমিক অ্যানিমিয়া, Leukocytosis due to inflammation of the joint and the systemic response to the antigen or the organism. Elevated CRP, C-reactive protein, elevated ASO, anti-streptolysin O or other streptococcal antibody titer, anti-DNase B test, and throat culture to group A beta hemolytic streptococcus, that is gold standard, and ECG, prolonged PR interval. So there is a conduction deficit, conduction defect. So the normal gap of depolarization to repolarization is lengthened because of the myocardial insult or myocardial damage. So the PR interval in ECG will be prolonged. Okay. What about the ASA and anti-DNase B test? These are the antibodies that are formed by the body own immune system against the group A beta hemolytic streptococcus. So these antibodies will be higher. The titer will be higher in serum. Okay. So for the diagnosis, according to the Jones, sir, 2 major plus essential criteria or 1 major plus 2 minor plus essential criteria is essential to diagnose rheumatic fever, along with the evidence of streptococcal infection. What type of evidence? Evidence of group A beta hemolytic streptococcus isolation in throat culture. Okay. So throat culture positivity is the gold standard of diagnosis of beta hemolytic streptococcus. So Aschoff cells, myocardium, Aschoff body or nodules found in the hearts of the individuals with rheumatic fever, they result from the inflammation in the heart muscle. So Aschoff cells, okay, Aschoff body বা Aschoff cells এগুলো দেখা যায়। আর Aschoff sinus কোথায় দেখা যায়? গল ব্লাডারে, তাই তো? রকিটাস Aschoff sinus। নে পরেরটা পাল্টা দেখি। এটা ডায়াগনস্টিক ক্রাইটেরিয়া যেগুলো আমি সব বলে দিয়েছি। এই যে রিভিশনটা হয়েছিল 1992 তে, তাহলে 44 সালে হয়েছিল, আবার 92 সালে হয়েছিল। প্রায় কত বছর লাগলো? 40 বছর লেগেছে রিভিশন হতে। ঠিক আছে। মেজর ম্যানিফেস্টেশন কার্ডাইটিস, পলিআর্থ্রাইটিস, কোরিয়া, এরাইদেমা মার্জিনেটাম, সাবকিউটেনিয়াস নোডিউল। মাইনর ম্যানিফেস্টেশন ফিভার, পলিআর্থ্রালজিয়া, ল্যাবরেটরি এভিডেন্স লাইক ইনক্রিজ ডিএসআর অর ইনক্রিজ লিউকোসাইট কাউন্ট। ওর কি শরীর খারাপ? তোর পাশের মেয়েটি কি হয়েছে? ওর কি শরীর খারাপ নাকি? হ্যাঁ, কি হয়েছে? মাথা ঘুরছে পড়াশোনা করে নাকি আগে থেকে? দেখ, আর যদি সত্যি শরীর খারাপ হয় হসপিটালে যা, পাশেই তো আছে। ইলেকট্রোকার্ডিওগ্রাম, প্রলং পিআর ইন্টারভেল। আগের ক্লাসটা কি খুব লেন্দি হয়েছে? হ্যাঁ, আগের ক্লাসটা কি ওভারডোজ হয়ে গেছে? ও ঠিক আছে, ডোজ কমিয়ে দিচ্ছি, দাঁড়াও, হয়ে গেছে। সাপোর্টিং এভিডেন্স অফ প্রিসিডিং স্ট্রেপ্টোকক্কাল ইনফেকশন। তাহলে আমার ল্যাবরেটরি ডায়াগনোসিসও লাগবে। নে চেঞ্জ কর দেখি, ওদের মাথা ঘুরছে। তাড়াতাড়ি এগুলো সব পড়াস না। পেনিসিলিন, পেনিসিলিন ট্রিটমেন্ট ইজ পেনিসিলিন, বেনজাথিন পেনিসিলিন, এরিথ্রোমাইসিন, ওরাল পেনিসিলিন, মানে যেগুলো হচ্ছে গ্রাম পজিটিভ কভারেজ থাকে সেই সমস্ত ওষুধ। মাইক্রোবায়োলজি পড়েছি, এই ফার্মাকোলজিতে পড়েছিস তো, তাই তো? এখনো হয়নি, ও হলে পড়বি। চেঞ্জ করে দে, মাথা ঘুরছে ছাত্রদের। আর্থ্রাইটিস, আর্থ্রালজিয়া কি হবে? এনসেড, স্যালিসাইলেট। সিভিয়ার কার্ডিটিস, আগেও বলেছি কর্টিকোস্টেরয়েড, যখন সিফিলিস পড়িয়েছি। যে কোনো ইনিশিয়াল ইনফ্লামেশন যখন ওয়াইড স্প্রেড হয়ে যায় তখন আমরা স্টেরয়েড দিই টু স্টপ দ্য ফসফোলাইপেজ A2 enzyme or to stop the cytokine storm at the earliest level of formation. Sydenham, Chorea, mostly self-limiting, but if not treated or if not resolved, then haloperidol or carbamazepine। এগুলো নিশ্চয়ই হয়নি, অ্যান্টিবায়োটিকের পরে হবে তো। ওগুলো হয়ে গেছে। সোডিয়াম ভ্যালপ্রয়েট, অ্যান্টিএপিলেপটিক ড্রাগ, হ্যালোপেরিডল, এগুলো দেওয়া যায়। নে চেঞ্জ করে দে। প্রগনোসিস, এগুলোকে চেঞ্জ করতে ছবিগুলো দেখাই ওদের। হ্যাঁ, এর আগেরটা দে। সো রিউম্যাটিক হার্ট ডিজিজ, দা আগেরটা দেখি, আগেরটা কি আছে রে? না এটা কিছু ছেড়ে দে, পরেরটা দে। সো রিউম্যাটিক হার্ট ডিজিজ, the valves are mostly affected And the order of the valvular involvement, just try to remember the mnemonic MAT. M-A-T. Most commonly involved valve is mitral, M for mitral valve, then A, aortic, and then tricuspid. Pulmonary valve is very rarely involved because of the continuous inflow of oxygenated blood with pulmonary blood. ওকে, পরেরটাতে ওদের ছবি দেখাই। সো অর্ডার, এই যে এটা কি হয়েছে দেখ, থিকেন্ড হয়ে গেছে, স্টেনোসড হয়ে গেছে, নরমাল। এরপর একটা নরমাল ভালভের ছবি দেখা। আচ্ছা এই দেখ, তোদের এইসব দেখাই বলে তোরা শুনছিস না। এই দেখ নরমাল ভালভ, দেখ অ্যাভাস্কুলার, থিন কাস্প, মোস্টলি ট্রান্সপারেন্ট, ফ্লেক্সিবল মেমব্রেন। এটা দেখ অ্যাফেক্টেড ভালভ, থিক। ভালভের লিফলেট গুলো দেখেছিস, মোটা হয়ে গেছে, ফাইব্রাস, স্কার্ড, স্টেনোটিক and fixed with blood vessels. So this is avascular. So there is transparency or lack of red color, but this is not transparent. This is more fibrous, more rigid and having more vascularity. দেখি পরেরটা কি আছে। So the clinical signs of carditis is high pulse rate, murmur, mitral or aortic regurgitation, endocardium involved, pansystolic murmur, mid-diastolic murmur may be found. Cardiomegaly, myocardial involvement, pericardial friction love due to pericarditis, prolonged PR interval. I told you earlier that conduction defect and the cardiac failure. So these are the clinical signs. Okay? Dekhi next day. Valve involvement in rheumatic heart disease, either stenosis or regurgitation. Stenosis mane ki? The orifice is stiff and orifice is narrowed down to that much extent that the upper chamber having the pressure of the backflow of the blood. That is called stenosis. Okay, the orifice is narrowed down. And what is regurgitation or incompetence? I told you earlier that the unidirectional flow of the valve is lost. তাই তো, unidirectional flow যেটা valve করা উচিত তার সাথে সাথে আবার রিগার্জিটেট করছে, মানে আবার ব্যাকফ্লো হচ্ছে, তাই তো। তাহলে ব্যাকফ্লো হলেও প্রিভিয়াস চেম্বারটা এফেক্টেড হতে পারে ডিউ টু ভলিউম ওভারলোড, আর স্টেনোসিস হলে কি হয়, প্রেসার ওভারলোড, তাই তো। দেখি ভালভ চেঞ্জেস তাহলে কি কি হচ্ছে, লিফলেট থিকেনিং হচ্ছে, কমিসুরাল ফিউশন হচ্ছে, শর্টেনিং এন্ড থিকেনিং অফ দ্য কর্ডি হচ্ছে, এন্ড অরিফিসিস ন্যারোড হচ্ছে। এই চারটে মনে রাখতে হবে ভালভুলার চেঞ্জেসে। কি কি হচ্ছে, লিফলেট থিকেনিং, যে ভালভ কাস্প, ট্রাইকাস্পিড আর বাইকাস্পিড, মানে কাস্প তিনটে আছে বা দুটো আছে, দোজ আর থিকেন্ড। কমিসুরাল ফিউশন মানে কমিসুর যেগুলো বলে, ভালভের কমিসুর বিটুইন দ্য জয়েন্টস অফ ভালভ কাস্প with the orifice, that is commissure, that will be fused, shortening and thickening of chordae tendineae and the narrowing of the valvular orifice. Okay, দেখি next কি আছে। So most common I told you MAT, M-A-T, mitral, then aortic, then tricuspid. So mitral valve is affected in 60 to 70% of cases. Mitral stenosis represent longer term chronic disease, commonly in adult. Most common complication in mitral stenosis is atrial fibrillation, because mitral valve is the connection of ki left atrium to ventricle. তাহলে যদি স্টেনোসিস হয়, এট্রিয়ামের উপর প্রেসার ওভারলোড হতে হতে এট্রিয়ামের মাসকুলেচারটা থিনড আউট হয়ে যায়, তখন টুইচিং হয়, তখন মাল্টিপল কন্ট্রাকশন হয়, সেটাকে বলে ফিব্রিলেশন। 300-350 হার্ট রেট থাকে, ঠিক আছে। মাইট্রাল স্টেনোসিস দেখা যাচ্ছে, এই যে এটা রিয়েল টাইম ইমেজ। তাহলে কমিসুরাল থিকেনিং হয়েছে, ভালভ কাস্পেড মোর টাফ এন্ড রিজিড হয়ে গেছে, and thickening of chordae tendineae with narrowing of the valvular orifice. দেখি next, aortic valve, next second most common, aortic regurgitation বেশি হয়, tricuspid valve, তারপরে হয় pulmonary valve, সবথেকে কম কমন। তারপরে কি আছে দেখা। So this is the image, এরা কেমন ভেজিটেশন দেখতে পাচ্ছিস, এগুলো এন্ডোকার্ডিয়াল ভেজিটেশনস। আর দেখবি কিছু